That was great end to this session. We have a time now for discussion. If anyone would like to put anything in the discussion group, fine. If any of the presenters have questions for other presenters, now's the time to speak up. I actually have a bit of a question. There's two 800-pound gorillas in the room. One of those is the lack of revenue, the lack of discussion of revenue. We're talking so much about cost, but the insurance companies we're not talking about as much. And so we're having a big revenue drain. And the second thing is, why are these implants so expensive? I mean, I kind of direct that a little bit to Andrew, on the idea of, these shoulder implants. I mean, as a chair, I buy them for the hospital, and I could put in a knee with three cones, and it's the same price as a shoulder. So trying to figure out, that the implant companies are making 20-30% a year. The insurance companies are making god awful amount of money, and we're trying to squeeze, and we're having 63% of our costs are the implants. So, what about the role of revenue, and why are these implants so expensive?
Yeah, I'll take that. I don't know why they're so expensive. I know manufacturing is a little bit more, let's say, for a reverse, because there are more components. Are they artificially high because there's less volume done? That's sort of what I was implying. Maybe. I don't really know the answer to that. I think there's something to be said about that, and that we're willing to pay that at this point. And I agree with you about revenue. And I sort of wanted, that's sort of what I brought up a little bit about how I do think this is a race to the bottom. And if you're in an academic setting, honestly, I don't think it's a black box. You don't know how much you're making, where it's going, you know, while in private practice, you know it to the details. If you're in a surgery center, you know the details. But at the end of the day, you are subject to what Medicare pays you. And in this case, for shoulder arthroplasty, or what commercial insurance pays you. And right now, it's good for shoulder arthroplasty starting January 1st. But if you look at hip and knee, it's going to go down. And, when I left Mass General as a resident, they used to say, I'll do 3 arthroplasties by 3. That's a great day. I just talked to a colleague who is a resident with me who does 8 a day. We're just gerbils on this, this wheel. And, maybe it's good for society that we're doing more at cheaper costs, but it's certainly not good for surgeons. And I'm not sure what the solution is. But that's my observation in a private situation, and trying to create revenue streams like surgery centers and implants and things like that.
Ira, I just want to make sure to
Sure.
take advantage of the fact that Susanna is still on here, as I want
Yeah.
her to make a comment about this, because it seems to me this is just simple economics. With hip and knee, you have large volume, lots of alternatives available. And so, of course, you're going to have an effect on pricing. When the reverse prosthesis came out, and the Grimaud prosthesis was the only one released, it was first mover advantage, and the hospital lost money on it, but had an ethical responsibility to deliver care to the patient. But as new entrants came into the market, the price was cut significantly, and that's really where shoulder is going. Now, shoulder is growing more than twice as fast as hip or knee. So it's hard to imagine that effect isn't going to come onto shoulder, and follow what's happened with hip and knee. We're just a significantly smaller book of business than hip or knee. Can you comment on that, Susanna, and maybe
Sure.
keep us honest on this question?
Sure. Well, I'll just share my thoughts. First of all, there's a lot of willingness to pay, right? So they can charge a lot because people buy them. And maybe because there's not enough competition, or the competition is not effective at keeping prices down. So nobody is undercutting the others in terms of setting a lower price point that could still get them sufficient margins. I don't know anything about the implant industry, I should say. But if I think about pharmaceuticals, their justification is generally based on we have to fund R&D. And I don't know how much R&D spend is present in the implant industry. I really don't know that. So, but that's something to assess, right? So are we funding the next generation of implants that are going to be 10x better? I don't know. With respect to revenue, how do we change that? Well, we need payers to pay for outcomes and not for procedures. How do we do that? My thought, again, this is just my personal opinion, so don't take it as a scholarly validated, is that we need to work with the employers. Whoever purchases the plans for their employees, whoever is ultimately paying for healthcare, is the entity that has the negotiating power over the insurers. And so, for example, Harvard University is self-insured, but we have contracts with Blue Cross Blue Shield, and I don't remember who the other option is. So if Harvard University were to push for, no, I really want you to deliver better healthcare, I'm going to hold you accountable, and I want you to drive and buy on my behalf better outcomes. That's how we start changing the revenue proposition. It's going to take a long time, but I am having a lot of conversations with employers trying to wake them up on this aspect that your health benefits should no longer be considered benefits, but should be considered part of your value proposition with your employees. So that's my overarching thought. I don't know if it's helpful.
There's a question from Hemath Aladu. Hemath, you have your hand up.
Hi, Hi, Doc. It's been a wonderful conversation, and I thank Dr. JP for the invitation. And the most important thing in the cost management here, what we are forgetting is the company support team which comes into the OR. In all our operation theater, we have always a company person who is trying to help us out. That increases the cost quite a bit. Most of the times we need a company person to give the implant proper size or assist us, or a physician assistant who comes into the theater. If this can be addressed by the associations, the implant cost will automatically come down for the companies also to manage a big physician assistant clinical group who can assist us in the operation theater.
Andy, Andy, could you comment on that? You did the analysis of the episode of care. Where does that find itself in terms of, is that in your pie graph that you showed?
It isn't. It's an interesting question. I don't know how much that adds, but it's a good question. I'm not quite sure how to even look at that. We'd have to ask the companies. I'm
That's
sure
where
that
the
adds so
weakness
much.
of the surgeon. That's the weakness of the surgeon, where we pay very quite a bit higher price for the company.
Yeah.
Yeah, I don't know. Good question though.
Yeah. Any other questions on this right now? I mean, I've
Yeah,
been.
I got a good question.
Yeah.
Hey, Andy and JP, great talks. It's Tiger from BU, and I just got a question for you guys. What is the cost of reverse at the Baptist and the versus the MGH? Who determines that cost that comes in? And I know for us, at BMC, I'm the only person doing reverse, and it's about $11,000 to come in for the reverse. I know the Baptist is cheaper. I try to do it at the Natick ASC with Shields, and they're, the guy there, Prashant, is telling me you got to come in under 6,000 for reverse to get in there. So who determines that cost? How do you make that determination, and what it is to come into your institution, and what it is at Baptist and the MGH? Thank you.
Andy, you in the co-management model there, you already touched on it. Why don't you reinforce that? Because I know your answer, I think.
I mean, the simple answer is it's volume. You do more volume, you're going to have lower costs. And if you can assure that you can do so much, you'll negotiate with implant companies. There are a lot of other things that make this confusing because these are published numbers. So they won't say, hey, this is what you get. They'll give you a rebate because they want to keep it artificially high. The low volume users, which is, the majority of people who do less than 20 shoulder replacements a year, they can pay the extreme amount, and then they'll give the rebate to the people who are high volume. And then surgery centers now that are huge everywhere across the country, they're really trying to be one vendor places. So all the arthroscopy towers, Stryker, implants or Stryker, they'll give you a huge discount if you just do one vendor. And that's how things are changing. So yes, it's about volume is the short answer.
I'll answer from my experience. We have this we've had in the past this VAT committee. Sometimes you find yourself on it and sometimes not. And usually if you're the one using the expensive product, you get berated by the supply chain people, and you get to see the numbers for the others. But, it's not really, we're not aligned, right? So if I save the hospital any amount of money, I don't get a thank you. If I lose the hospital any amount of money, I don't really get to see the numbers like you showed there. So we're doing the exact opposite of what your group is doing and what Hans was talking about. And so at the end of the day, it feels to me like the hospital is making decisions on their own. I honestly don't know how they come to arrive at their decisions. They do the negotiation. I have no idea about how they manage the RFP, et cetera, because that's not shared with us. We're not part of the process where I work, at least to my knowledge, we're not.
And if I could piggyback on that, and I'm making a value judgment here, but this is one of my issues with academic medical centers, and I sort of alluded to it. It is a black box. You don't understand where all these numbers are coming from, and I think transparency is key. And this is one example of that.
I think this is a great discussion. JP, you want to sum up some things?
Yeah, I mean, the purpose of my thinking of the Codman group, and the collaboration that we have here, which is great, is that we talk about things that we don't usually deal with day in and day out, but they're central to the survival of, our engagement and involvement in patient care. And they're not the things that we learn through our training. And so bringing people together like we have here really is enlightening for people that are in a position potentially to change the way we do business, to change the way we function, to change our connection to our institutions and collaboration with our institutions. Otherwise, I mean, we have an unsustainable model with the way things are going with a GDP now was about 18%. The only way, my way of thinking, to change this is to change it from within with some kind of a collaboration and alignment that so far has not existed, period. And frankly, taking care of a lot of politicians on both sides of the aisle, like I've done, the vast majority of these folks have no idea what they're voting on. Zero. Probably the smartest politician ever took care of, and it's not HIPAA anymore because he's passed away, was Orrin Hatch, who was very, very knowledgeable and aware of this, and we had a very good discussion about it. But most of the other politicians I've talked with, they don't have the foggiest notion about all of these things, and they largely do groupthink when they vote on things that affect all of us. So we have to play a more active role. We have to produce data. There's an expression that Lenny Johnson, who is a famous entrepreneur, used. He said, there's a war out there, and data is ammunition, and physicians don't have any. And so, I think Bob signed off, but one of the most important things that Bob said, if you can't manage it, you can't measure it. If you can't measure it, you can't manage it. And if you don't manage it, you can't improve it. And we are woeful at measuring things, let alone using them as a basis for changing the way we do business. And that's what this is all about, getting everybody enthusiastic about looking at the data and using it as a lever to change things rather than your opinion as your lever. And that's the only way we're going to change and improve healthcare in this country, in my opinion. So I think we're at time. We're 7 minutes over time. I really appreciate everybody coming. For those who missed this, share with your friends that this will be posted on the Codman website. There may be some publications coming from this in Joey, depending on what Ira thinks about. And Avant-Garde has been a very, very important partner in all of this. And again, I said measure. Avant-Garde is the key to doing that because it automates the process and has a lot of smart people to help you answer the questions that you need to ask in the first place. So thanks, everybody. Have a good evening. And thank you so much for participating in this 9th meeting of our group.